Hello, everyone. My name's Ruth Bergen. I work with RIN, and I'm opening this webinar to introduce the latest data on gender responsive harm reduction services for women and gender diverse people. The background, first of all, to this mapping exercise is that we recognize that around the world there are, fortunately, more and more services starting to apply a gender lens in their harm reduction work, but we're also concerned that many of these services are experiencing resource and other constraints that make it difficult for them to find opportunity to document and promote their important approaches. We also recognize that there could be advocacy advantages, particularly for the countries that have very few or no such services, to be able to point to other countries in their regions to help support their advocacy to make harm reduction services available for these communities. I'll talk a little about the method we employed, first of all. This effort began back in 2021 through the existing allyship of our network. We were able to engage focal points in the 8 major regions of the world to in turn reach out to particularly women and gender diverse people in countries in their region who may be familiar with available services. But we cast the net wider also to include harm reduction practitioners and others. The mapping has also involved some desk review work and has incorporated qualitative data from consultations with communities through the work of RIN. It is very much, and this should be underscored, a living document. This is not a set in stone report, and we do implore, ask everyone to have a good look at the annexes, particularly the annexes for your respective regions, and get back to us if you have any updates, if you know of a service that is new or a service that has closed, and also if you know of better links that we could be using for people to better understand the services that have been identified. The general findings were that, since 2001, with our most recent data collection, there was a modest increase in the number of services, but overall, harm reduction services that are gender responsive are still rare globally, even in countries where there were more services listed than others. It is clear that the available range of services is not adequate to meet the scale of demand in any country. It's interesting to note as well that the existence of these services doesn't seem to depend necessarily on whether the setting is a resource-constrained one. We see, for example, pretty much at a glance in the annex section that Canada is the country we found most services that met the criteria. And yet also in Myanmar, there are a number of pace setting services. And so again, we see that harm reduction services wanting to make their programs more accessible to women and gender diverse people need not spend a fortune. It can often be about better connection with allied services and internal service adjustments that don't necessarily break the budget, but do involve putting on a gender lens. Having said that, of course, some things do cost money, and we're really hoping that this effort helps people tune in to what is missing in their own services, particularly also when it comes to program budgeting and grant writing. I also want to, at this juncture, highlight how many countries alarmingly had either no harm reduction services or harm reduction services that had no gender lens whatever. So that's an important takeaway from the global mapping, of course. While on that, I'd like to just revert for a moment to the cover image that we have for this mapping report. You'll see the eye representing the gender lens, and within that, a woman um, under a tree with fruit, only one piece of fruit in it that is out of reach. And I just wanted to underscore that imagery as one that indeed is reflected in the contents of our findings. We also note that globally there is now enough normative guidance on what this programming should look like for women and gender diverse people. We're not suffering a lack of normative guidance or training materials, some of which are linked in this report also. And it really seems to come down to communities working around harm reduction and also those holding the purse strings becoming aware of the scale of need and the urgency in developing an adequate response. Rather than trying to detail all the outcomes from the report, what we've decided to do is introduce a kind of teaser, if you like, of summaries from 3 of the regions, and those summaries will be presented by the respective focal points that helped with gathering the data in their respective regions. And it's hoped also that this will encourage everyone to look deeper at their own country and own region in this respect. The webinar is pre-recorded, but having said that, we do encourage you to post any questions into the Q&A or into the chat section, and we will get back to you. Please also note that the entire webinar is being recorded and will be uploaded to our YouTube channel and shared back with all those who have registered and beyond. So without further ado, I'm pleased to introduce the first presentation, which will be introduced by Joelle Puccio, who is a person who uses drugs and a registered nurse and co-founder of the Academy of Perinatal Harm Reduction. They are also a member of the strategic advisory body of RIN. They became passionate about advocating for people who use drugs after realizing that everything they had been taught about drugs from childhood through to nursing school was wrong. Thank you, Joelle.
Hi, I'm Joelle, and I have the honor to serve as the North American focal point for the RIN Global Mapping Project this year. So, although we are calling it North America, we understand that Mexico is part of North America. However, for linguistic and cultural reasons, it's going to be included with Central and South America. So, we're looking at Canada and the United States. We had 11 respondents, which is not very many, but we did target people that we knew had really diverse webs of connections throughout their region. So, although we had a small number of respondents, we did have 43 programs. And I think a big part of why our folks were so well connected is because most of them were people who use drugs. So, some trends that emerged both in the United States and Canada were a lot of services for women by women who use drugs. We've been seeing a lot more integration of medical and social services within harm reduction programs. Community building efforts such as support groups, social events, baby showers, things like that, just really trying to make connections among people in these communities. A lot of folks need legal aid because it is routine and typical in Canada and the United States for the state to remove children permanently from their parents for no reason other than substance use. So a lot of these families are requiring a lot of legal aid. We've seen integration with sex work and gender-based violence, both organizations that do harm reduction, incorporating outreach to sex workers and people who've experienced gender-based violence, as well as those sex worker and gender-based violence organizations starting to integrate harm reduction. We've seen an increase in birth workers integrated into these programs. Birth workers are sometimes also called doulas, and they are a non-licensed professional whose job is to assist with anything somebody needs. So they're really knowledgeable about birth and baby care, breastfeeding, and they can also help with cooking and picking up kids from school and anything else that a person needs in that moment. Some things that are specific to Canada are just more services are integrated into these programs. So they'll have harm reduction services like an overdose prevention center paired with housing and case management and medications for opioid use disorder. And part of that is because in Canada, the funding situation is just a lot better than it is in the United States. There are several 24-hour overdose prevention centers that are specifically for women and staffed by women, which is super cool. We've also seen a bunch of Indigenous programs identified in Canada, which is very important because we know we have to provide culturally responsive services if we want to actually reach these communities. In the United States, a couple of interesting models have popped up. We have an infant detoxification facility, which cares for babies who are withdrawing from opioids and also provides case management and social services to their families in the same location, which is really cool. We've also seen coming out of Urban Survivors Union in North Carolina, the Narcofeminism Story Share. They just published a paper on that, and I am going to ask that somebody drop that in the chat since it is 1 in the morning where I'm at, and I will not be present when this is shown. The Narcofeminism Story Share is an innovative training program where people who use drugs write their stories in a strengths-based way. They then use these stories to create anti-stigma training curricula. Very, very cool. Some gaps that we see are gender diversity. There were lots and lots of programs who reported that they serve women and gender diverse people, but it didn't seem that there were any specific services for gender diverse people. They were just typically kind of lumped in with women. We have funding gaps everywhere. More particularly in the United States, the funding scheme is a little bit more favorable in Canada, but we could use more funding everywhere, especially for those programs which reach rural and reservation communities. A lot of these folks are far away from large cities, far away from big highways, and just more difficult logistically to reach. And so we need more funding for that. We also did not have any programs reporting that they provide childcare, which is a huge need because we know that the years when we're most likely to use substances coincide with the years when we're most likely to birth and raise children. So right at the top of my list of recommendations is to decriminalize drug use and decriminalize pregnancy and parenting. These are intersecting issues that affect women and children and families in the United States and in Canada. We need to abolish our punitive systems and not just thinking about prisons and police and jails. We need to be rooting out the punitive systems that have infiltrated our so-called systems of care. We know that social workers, doctors, and nurses are among those most likely to call the police on their patients when they present to their hospitals and clinics seeking help. We need to make sure that when we're providing funding, that it is making it down to the community level, to the people who are doing this work. We have so many programs that are on shoestring budgets and that are only staying alive because of passionate people who use drugs, who know that if they don't do this work, then nobody else is going to. And we need to fund those programs. We need to have lesbian, bisexual, transgender, queer, intersex, and asexual specific services integrated into all of our harm reduction programming. We need also to expand existing models. The great news about all of these gaps and recommendations is that we have amazing programs that are being developed all over the place. And we need to learn how to adapt and expand these models to other locations. Thank you.
Fabulous. Thanks again, Joelle. So our next speaker is Vielta Parmenko. Vielta is a Ukrainian activist for the rights of women with intersecting marginalization, as well as for key community members. Vielta is the chair of the NGO Club ENI in Ukraine and is also a member of the strategic advisory body of RIN. Thank you, Vielta.
Hello, everyone. My name is Vilta Parhomenko, and welcome on gender-sensitive approaches to harm reduction services in the ICA region webinar. I am the VRIN focal point for Eastern Europe and Central Asia, ICA region. And today we'll walk you through the findings from our mapping project, which focuses on identifying key harm reduction services, challenges, and innovative approaches for supporting women who use drugs across the region. So, as you see, we conducted this mapping with 25 respondents, 44% of whom identified as people who use drugs. This highlights the importance of listening to lived experience to inform our work. Our goal is to improve access to tailored gender-sensitive harm reduction services for marginalized women in the ICA region. And so let's see what gender-sensitive harm reduction services we have. And one of the key findings from our mapping is the need for separate and gender-sensitive services. For example, in Belarus, the Belarusian Association of UNESCO Clubs provides services exclusively for women during separate hours. They offer HIV testing, STI consultations, and harm reduction supplies in a space staffed by female professionals. In Moldova, for example, the organization UNA has dedicated spaces for women in cities like Balti and Chisinau. They also provide shelters for temporary accommodation. In Slovakia, organization conducts women-only sessions in drop-in centers, creating a safe and stigma-free environment for sexual health education and harm reduction. The takeaway here is that gender-sensitive spaces really reduce stigma and ensure privacy, which makes it easier for women to seek support, because when organizations start to provide harm reduction services for women, they see that they see the increasing number of women who use drugs as clients of the organization of harm reduction services. So it works on that way. And let's speak about comprehensive health and social services, which address multiple needs in one place. For example, in Kyrgyzstan, the organization Public Foundation Asteria provides a range of crisis services, including shelters, medical and legal support, and harm reduction education for women who use drugs. And in Tajikistan, Spin Plus focuses on HIV testing, peer counseling, and legal services specifically tailored for women who use drugs and women living with HIV. And we see that these integrated approaches are critical for addressing physical, mental, and legal needs holistically, especially for women who use drugs, because if you face it with stigma and discrimination in your society, it's really not easy to go to different places to get different services. So if we see this holistical approach, it really works better. And let's speak about community-based approaches and peer support. For example, in Ukraine, and I'm from this country, in organization Klabine, they have a WINGS program, Women Initiative New Goals for Safety. And it is a peer-led initiative that screens for gender-based violence among women who use drugs and connects them to HIV services, to harm reduction services. Also in Slovenia, the Stigma Safe House provides safe housing for women who use drugs without requiring abstinence, and it's really important. And their peer-led approach fosters trust and support survivors of violence. And in Moldova, former offers harm reduction education and sexual health support through community-led efforts. The key takeaway is that peer-led initiatives increase trust and improve service uptake as community leaders often better understand and relate to the needs of the target population. And when we say about peer-to-peer for women who use drugs, so peer consultants must be also women, female, not male. Okay, yeah, and these are really great approaches, but we see that we have many challenges and gaps in such services in ICA region. So, for example, shelter options are limited in Kyrgyzstan and Moldova, where stays are often restricted by time, preventing long-term support. Also, many services like Tajikistan Spin Plus face resource constraints affecting their ability to provide consistent meals and materials. And also legal barriers in countries like Russia make it difficult to reach women who use drugs without stigma or repercussions. And sure, punitive drug policy in ICA region in other countries is really important challenge for all people who use drugs, and especially for women who use drugs, because, for example, if women have children, she can really fair to get harm reduction services because she feels that social government services can take off her children because her drug using, because there's laws, for example, in Ukraine. And addressing these gaps is really important to ensure sustainable and reliable support, particularly in regions with limited funding. Let's move to next slide. Let's see on time and availability across the ICA region. The region is diverse, and so are the services available. You see here that Belarus implements a gender-sensitive approach with separate hours and staff for women. Kyrgyzstan and Moldova offer shelters, but their capacity is often limited. Ukraine's WINGS program combines gender-based violence screening with HIV testing and counseling, created a model of integrated support. And this diversity highlights the need for tailored solutions to meet the unique needs of women in different contexts. Because we need really different approaches to cover all needs of women in harm reduction services. It's really important. So, which conclusion and recommendations we can provide? In conclusion, gender-sensitive and comprehensive services are essential for effective harm reduction among women who use drugs in ICA region. Peer support and community-led models significantly enhance accessibility and trust, leading to better outcomes. Based on our findings, we may recommend expanding shelter access in Kyrgyzstan and Moldova by increasing funding and support for long-term options, sustaining and scaling peer-led initiatives like Wings in Ukraine and the Stigma Safe House in Slovenia to strengthen community involvement, advocating for legal reforms in restrictive regions to enable safer, stigma-free access to harm reduction services. Thank you for your attention, and I look forward to any questions you may have. Let's continue working together to make harm reduction more accessible, inclusive, and impactful. Thank you so much.
Fabulous. Thanks so much, Vialta. Now I'm really pleased to introduce our last presenter, last but certainly not least, Putri Tanjung from Indonesia. Putri is a peer support coordinator for people living with HIV in West Java and is involved in the women's division of the National Network of Indonesian Drug Users, and is also a member of the board of RIN. Thanks very much, Putri.
Hello everyone. I will present about gender responsive harm reduction services in Asia. Cumulative responses were received from Thailand, Japan, Myanmar, India, Indonesia, Laos, PDR, Malaysia, Nepal, Bhutan, Pakistan, Philippines, and Vietnam. There was only limited information on the degree of involvement of women and gender diverse people who use drugs in program or service designed for some countries. Slide. Indonesia, Japan, Thailand, India, Myanmar, and Nepal, and possibly Pakistan reported specific harm reduction services designed for women and or gender diverse people. These were no nationwide programs. This finding is particularly alarming as an estimate half of the global population of women who use drugs live in the Asian region. Next slide. I would like now to provide a bit more detail on services identified in two countries, Thailand and Myanmar. These two in some ways provide an example not only for replication in their respective countries, but as an example to other countries in the Asia region and beyond. Thai provides harm reduction services for women, men, and gender diverse people across numerous sites in Thailand, where there are significant population of people who use drugs. In a number of sites, Thai runs services tailored especially for women, and in future programs, aim to expand such services along with those that are inclusive to gender diverse people who use drugs. Health Opportunity Networks supports gender diverse people, including sex workers, providing HIV prevention education and safer sex communities. SON is increasingly focusing on harm reduction service provisions and advocacy through established referral mechanisms to services that are gender responsive. While not included in the Service Mapping Index, it is fantastic to note the establishment of We Trust, the first Thai network of women and gender diverse people who use drugs. We wish them all success in playing a role in elevating the voices of community as harm reductions hopefully expand further in Thailand. In Myanmar, despite the junta coup, harm reduction providers have continued to set the bar high for the region and beyond for gender-responsive harm reductions. Best shelter include a woman-exclusive drop-in center, women safe spaces at the general drop-in center, community-based harm reduction services, sexual and reproductive health services, nutritional support, job creation incentives, training and capacity building for women who use drugs. The services of MAM include a separated waiting area for cis and trans women with a transgender-specific clinic, warm meals, sexual life, drug use, and risk reduction counseling, gender-based violence care, prevention and treatment of HIV, STD, cervical cancer, breast cancer, family planning, and facilitated referral for buprenorphine and methadone. AHRN provide integrated sexual and reproductive services, including family planning, with pre or postnatal care referral for special medical treatment to hospital for child delivery or miscarriage as needed. The center also offers counseling to promote open discussions between partners about safer sex and drug injections. Where possible, women peer-driven outreach and social network screening have been established. Women-only corners are set up in AHRN's project sites. Meta provides woman-focused services through employment of women outreach workers, woman-friendly spaces at the drop-in center, and woman-focused health education sessions. Lastly, MDM facilitates gender-responsive specific harm reduction services through a women's advisory group. The group regularly engages with women who drugs in efforts to overcome barriers in accessing health care services and for sharing harm reduction knowledge. Specific medical services are also available for women who use drugs, and there is also a woman-only drop-in center in some sites. The impact of punitive drug control. Across the region, the intersections between patriarchy and punitive drug policy create environments of violence against women and gender-diverse people who use drugs with impunity for perpetrators, along with effective exclusions from available gender-based violence services for people who use drugs. This violence can occur in various contexts, including intimate relationships, family settings, public spaces, and at the hands of law enforcement. In some countries, there are accounts of women reporting violence to police, which has then led to the woman being arrested on drug charges. Gender-diverse people who use drugs in regions where same-sex marriage is largely banned are likewise experiencing intersectional discrimination and high rates of violence. Drug treatment is rarely evidence-based and is associated with gender human rights violations, while incarceration rates have skyrocketed, conflicting markedly with the commitments of member states to the Bangkok Rules. Next slide. The lack of access to effective sexual and reproductive health and harm reduction services for those in the community and people confined in close setting across the region is a serious concern. The criminal justice response intensive stereotypes of women who use drugs as bad women, which contributes to stigma and discrimination against a woman as well as gender-diverse people from both social networks and state institutions. These are expressed by the lack of legal and social services, abuse of privacy and confidentiality by staff, and the normalization of violence and abuse of power by criminal justice officers. Next slide. Resilience. In response to these issues, women who use drugs in Asia have not been passive. Many groups or networks of women and gender-diverse people who use drugs have actively challenged the structural oppressions that impact our communities and advocate for the services we need. There is an example photo of annually repeating action from Indonesia. In this case, campaigning to end gender-based violence against our community. Similar actions are periodically taking place across our regions, spotlighting resistance and resilience among us. Thank you.
Okay, I'm sure you all join me in thanking our fabulous panel of speakers today. And again, I would remind you, please do post any questions or comments that you have into the chat, and we will endeavour to get back with any responses to any of your questions. And also, if you wish to watch the webinar again or to share it with others, we'll be posting on social media once the recording has been uploaded to our YouTube channel. Thanks very much for joining us. Bye-bye.